The All Me Augmentation surgery is basically an abdominoplasty procedure, but instead of simply taking the tissue out and removing it and discarding it, you dissect out the perforator. That's really the only difference in the abdomen. And by using the microfascial incision, where our incision is between 1.2 and 2 centimeters, it's really not a big fascial incision. It's only in the anterior sheath, and therefore we're not really adding much morbidity to the abdomen. We're taking out the tissue with the blood vessel and the perforator, and because we typically don't need to use the entirety of the tissue, you can truly customize the shape of that tissue when you transplant to the breast in order to transplant only what you really want to. In the breast, we're very careful. We put the tissue underneath the pectoralis fascia. We do that because there are concerns about what if this patient gets breast cancer in the future. Well, if we put it dermacyte up and we put it underneath the pectoralis fascia, if God forbid that patient does get cancer in the future, we can go back and do a mastectomy in a truly oncologically sound manner, maintaining the deep flap tissue on the chest wall, and in essence, you've already done your breast reconstruction. So that's another addition that we have to talk about. For the most part, in the chest, the approach depends so much on what we're doing with the chest, whether it's a primary augmentation, an augmentation that does not require a lift, or an augmentation with a capsulectomy and removal of old implants. So all of those have their own little nuances that we have to consider when we're doing the All Me Augmentation.
And I would say the feeling of getting into the All Me Augmentation is, I think every DIEP flap surgeon knows that satisfaction when you're converting a failed implant and replacing it with a DIEP flap, or if somebody's having a nipple-sparing mastectomy and you're doing an immediate reconstruction with a DIEP flap, that's probably the greatest result. It's a similar feeling. Doing a primary breast augmentation, mastectomy with your own tissue is kind of like that nipple areola sparing mastectomy with DIEP flap. And similarly, taking out an implant, a failed implant, and replacing it with nice, healthy tissue, you just have that sense of satisfaction. That patient is relieved of any foreign body for the rest of their life.
And then we have to talk about primary augmentation, especially patients who don't need a lift. There are some advanced techniques that we do in those patients for the All Me Augmentation that allow us to do very minimal access incision. We typically will make on the right side, where the blood vessels we know in the chest are larger, we'll make about a 6 centimeter incision. We'll approach that, we'll dissect the pocket, and we'll prepare the vessels through that. But on the contralateral side, the left side, we'll make a 4 centimeter incision, and we'll put the flap through, tunnel the pedicle over to the right side, and do all of our microvascular work on the right side, daisy chaining the flaps, so we can truly do an augmentation that is not much different than a breast augmentation with implants.
Yeah, I think it's a very slick and very thoughtful approach.